Okay, all right. So I think we'll get started. I'm Dr. Henry Wong. I'm a nephrologist in Fraser Health and primarily working in Abbotsford. We're presenting this as a team. So I'm the physician, and I've got the rest of my team here, and of course, Bobby's the social worker, the most important person.
So I'm Heather Renwick. I'm a nurse on the kidney care clinic team with Dr. Wong and Bobby. I've worked in hemodialysis for many years, and I've spent the last 4 years in kidney care.
And I'm Bobby Preston. I'm a renal social worker and work as well in the Abbotsford Kidney Care Clinic. And I also have involvement with the BC Renal Social Worker Professional Practice Council. And I also had the opportunity to work with the working group that helped put together this guideline. And we'll talk a little bit more about what that group was. And we're going to talk about a few things. We're going to ask you if you wouldn't mind just holding your questions until we get through the information part. This is an overview. We're not going to be getting into things really in depth in this workshop, but we are going to get to a place quickly, hopefully, where we're going to talk about some case studies, and we want to have some interactiveness with you. And then there's also going to be a place for questions at the end. So we're going to try to get through our first sort of half an hour talking as quick as we can so that we can include you in this workshop.
Okay. So a quick overview of the session. I'll go over what anxiety and depression is and how it relates to our renal patients. And then we'll go over some of the symptoms and indicators, then the guideline and the recommendations. After that, we'll talk over the tools that we use to assess these patients and potential interventions that can be done. After that, a couple case studies, and then questions and answers. So having said that, I'm going to actually start off with a case study, an actual patient of mine. She's now 52. She was 48 when she was initially referred to my office, and the referral was for proteinuria and early stage 3 chronic kidney disease. She's got other health problems, as most of these patients do. So she has high blood pressure, she's got diabetes, poor lipid control, as well as being overweight. And after the initial assessment, a couple risk factors were identified. Obviously, the proteinuria, but also the fact that she's got very poorly controlled blood pressure and diabetes. Now, during this initial visit, she certainly appeared quite pleasant and cooperative, really wanting to please the doctor kind of behavior. But there were some warning signs. So she was quite shy, she avoided eye contact, and really seemed to be quite overwhelmed. So really, whatever I was saying didn't quite seem to register. But because there was limited time, we wrapped up the visit, and I booked her for a 6-month follow-up. So far, so good? Of course. She didn't show up for the 6-month follow-up, and we called her and couldn't reach her. So, she became lost to follow-up, right? And then a few months later, she actually walked into the office, and she lives in Langley, so it's quite a long distance for her to travel. She walked in the office asking for a follow-up, which we accommodated within a few weeks. Kind of the same issues came up. Ongoing risk factors that were not controlled, really high hemoglobin A1C, really high blood pressures, and clearly she wasn't taking her medication, she wasn't using her insulin. And of course, as kidney concerns continue, then she developed high potassium and needed dietary restrictions, and you can see a buildup of problems. For the first couple of years when I was seeing her only in the office, this ongoing pattern of no-shows or sort of late calls to cancel or just being really late to the office, this was an ongoing problem. And of course, the ongoing problems with the blood pressure, diabetes, and just not adhering to her medications. Unfortunately, she suffered an acute kidney injury, and this was in the context of a heart attack, where she ended up in hospital and needed a bypass surgery. And when she ended up coming back, her GFR dropped to less than 20, and then in that context, she was then referred on to the kidney care team. So I'll just pause there for a second. Are there any comments or questions? Just maybe one or two. Okay, I'll trigger you. Is this a bad patient? No. Is this a non-compliant patient? Because that's typically what we would sort of subconsciously say that's the case, right? Was there something that was missing in this patient that we didn't address because we were so limited to being in the office setting? Probably. Now, I mean, we're trained to focus on physical problems, the medical side of things, and historically that's what we're trained to do, right? And I think for the nursing staff as well, it's kind of the same thing. The office visits are very limited in terms of what we can do. So, I got half an hour. I can focus on the medical problems, but I'm not sure I have time to look into the psychosocial concerns. And I think that's a problem. So why do we care about their anxiety and depression, especially from a renal perspective? So what is depression? Depression is a mood disorder and affects how a patient feels, thinks, and behaves. It is triggered by biological, psychosocial, or environmental factors, for example, like a traumatic life event, and you could include the diagnosis of chronic kidney disease or receiving that diagnosis as a trigger. Major depression disorder is one of the most commonly diagnosed mental health disorders. I'll call that MDD from now for short, and it's a spectrum disorder. It can range from mild to severe. So MDD is not transient. It's not unhappiness that's related to life experiences or stress, and certainly it's also not, when someone just grieves from a loss in their life. They may have a single episode of MDD, or they may have recurrent episodes, or be chronically depressed. In the non-dialysis population, the rates are quite high, and it really depends on what studies you read, but self-reported rates are 7 to 47%, and in a more structured interview, there's a 20% prevalence rate. Until recently, most of the research regarding depression and anxiety has focused on patients who are already on dialysis rather than the CKD population, and they also focus on how depression and anxiety relate to these patients when they want to withdraw from dialysis. What is amiss is how the CKD population deals with this problem. And this problem does occur across a wide spectrum of the renal patients. Some studies, for example, show that CKD patients without cardiac or diabetic complications, which are patients we generally would say are low risk, they actually have more anxiety and depression than patients on PD, which is quite surprising. And then, again, another surprising fact is patients who have had a kidney transplant from a live donor, again, people who you would tend to say are fairly healthy and in terms of our renal population, again, they also experience more mood problems than PD patients. So now if we underestimate the importance of psycho-emotional functioning of our patients and how that relates to their health, then we really miss an early opportunity to intervene. If we're able to intervene sooner, then our patients will be better equipped to deal with their disease trajectory. Just to go back, so dialysis population, 20 to 30% prevalence rates for depression, and if you use a structured interview, a semi-structured, it's generally lower. I guess the bottom line is that the rates in CKD, so pre-dialysis, are actually equal, if not greater, than dialysis populations. The clinical depression may have preceded even the onset of their CKD or maybe triggered by the CKD. And again, same goes for dialysis, before dialysis, or triggered by the dialysis itself. Sometimes it's obvious when they present, so they come and on their little referral note, there's established diagnosis of depression, or the patient is quite obviously presenting symptoms consistent with depression. Occasionally, but it's really rare, they would come and actually directly disclose the fact that they have depression. More often, it's more subtle signs that you have to look for. So most of the time, it's not obvious. So unless we attend as a team to the psycho-emotional dimension of this person, we would miss these important critical red flags, and then this places the patient at risk for further complications, both medically and psychiatrically. Elderly patients with cognitive decline are in a special risk, so their mood disorders are often even more pronounced. In terms of risks, depression is common and underdiagnosed, and we should pay special attention, especially when it comes to older people. The physical illness may precipitate the psychological stress, and they experience their physical illness differently, so they experience it both subjectively, so psycho-emotionally, as well as physically, objectively. A lot of these patients have comorbidities, and which compounds their depression. So 12 to 42% of older adults with health problems that interfere with their daily activities have significant depression or anxiety. So in our population, we serve a lot of people with comorbidities and also significantly higher risks of anxiety, depression than the general population. So I'll switch gears quickly. What is anxiety? So anxiety is an adaptive response. It's disorder only when it becomes so excessive and uncontrollable that it impairs on the patient's ability to function, and it can manifest in a whole different ways. Anxiety is also a group of disorders, as you can see there. They frequently will coexist in patients with depression. So we have to be very mindful of the fact that patients who are depressed may have anxiety and vice versa. They're only 18%, so anxiety is 18% in the general population, but in our population, in the non-dialysis CKD, 28 to 54%, and in the dialysis population, reports of 30 to 46%. Okay, I'll stop there and pass it on to Heather.
So CKD and anxiety and depression compound on one another. People experiencing chronic diseases as well as anxiety and depression are likely to become quickly overwhelmed and not to look after themselves adequately, physically and emotionally. If the patient has underlying anxiety and depression, they may need information delivered to them incrementally and presented in a different way than the patient who is accepting of their diagnosis and ready to learn. Given the personal commitment required for renal replacement therapy and the implications in choosing home therapies or conservative treatment, the lens through which our KCC patients receive information and are able to engage in informed decision-making and treatment is a significant ethical consideration. Awareness with regards to anxiety and depression offers a possible key to facilitate the individual to engage effectively, to be able to hear information and ask questions, and explore ways to work on managing the CKD, as well as make informed treatment choices. Some treatment choices require confidence and self-efficacy, so it's important that we are recognizing anxiety and depression.
And we're going to have to pick up the pace a little bit so that you guys are going to be able to interact with us. So I think what we've been trying to do thus far is begin to show the justification for why the BC Renal Agency would want to be paying attention to this other comorbidity. And we're using we missed a slide about the goals, about using the actual BC Renal Agency guideline as the framework for the presentation so that hopefully we as interprofessional teams will be able to better recognize and meet the needs of our patients in the best interests of successful transitions and best outcomes for renal patients. So the guideline, just so that you're aware, it is grounded in research. It was developed with the chairs of the BC Renal Agency, so that would be Dr. Monica Bolio and Janet Williams. It included psychiatrists, nephrologists, family physicians. I didn't say this already, did I? No. Okay. Renal nursing and social work. And so the guideline that we're talking about is posted on the BC Renal Agency website. You will be hearing more about it. It's sort of the beginning stages of ensuring that everybody's kind of on the same page. And it also means some education for our directors and our management. So raising awareness around the experience of the CKD patient and this huge prevalence that Dr. Wong just talked about within our renal population and the importance of assessing and addressing and actually making the appropriate referrals within the team. And then we're talking about the role and the scope of the kidney care clinic. We're also talking about the boundaries of kidney care clinic and renal in terms of addressing and making sure that our patients have the right kinds of supports. So we've heard a bit about a case study. We've heard a bit about anxiety and depression. I think I want to say something about what does that look like when it first comes to kidney care clinic, or even what it looks like when people are transitioning onto PD or onto hemodialysis, when people are, whether they have it at a clinical level or not, these are times that are exacerbated. And what does it look like? It looks like, I don't know why I'm going backwards. It looks like defense mechanisms. It looks like catastrophizing. It looks like denying or minimizing or avoidance. When we're in kidney care clinic, we see evidence that people are operating in their defense mechanisms. When we get referrals with people with relatively high GFRs on the scale of things, but when they come to us, they are absolutely terrified and under the impression that they're going to be tied to a machine for the rest of their life by next week. We also see the defense mechanisms in place when we have people coming in stage 4 or stage 5, very low GFRs, and they're yet to be convinced that they actually have kidney disease. So we need to be able to attend to the medical realities and the patient's perspectives as both extremely valid, and we have to start responding to their perspectives in ways that create change so that we've got a more accurate picture of what's going on. If we don't, people experience cognitive distortions. An example of that would be selective abstraction. So they're hearing our story and the things that we're giving them, but they're going to hear only pieces of that. They're going to disregard other facts, and that's going to have a real impact on making appropriate choices, and that really matters to us in renal in terms of treatment. So we can be spinning our wheels if we're caught up in reframing the facts about their CKD or the benefits of any kind of preferred modality, and rather than exploring and reducing their anxiety, that is the barrier to moving forward, either with self-management or our decision-making, or actually having them move forward, having not really provided us any informed consent because they really haven't been able to hear or understand anything that we've been offering. So I think I'll turn this over to Heather for a little bit.
So I had 20 years of hemodialysis experience before coming to KCC, and there are the obvious differences in the two renal areas. But the greatest thing that I didn't anticipate was the degree of anxiety and depression that presents with patients who are experiencing a new diagnosis or a change in their chronic condition with a referral to KCC. Patients admitted to KCC may present with clinically significant anxiety and depression and at lower levels of anxiety and depression. This really speaks to how patients react to the information they are being provided. Our patients aren't being attended to in an emergency room crisis. They're not experiencing an acute admission or adjusting to a dialysis regime. That our patients need to understand that they have kidney disease, often without symptoms, that they are in an outpatient clinic without the medications, equipments, and hospital beds, that they need to participate in decision-making provides a unique opportunity to evaluate patient perceptions that wouldn't normally be seen in a focused physician's appointment or an acute admission. So being aware of how symptoms may be interfering with our efforts to communicate and educate patients really speaks to the importance of clarifying the patient's understanding of health information and addressing their perceptions and emotions prior to proceeding with giving further information. Our demographic, for the most part, is still operating on the myth that it's a personal weakness to experience depression or anxiety. This has implications for lack of acknowledgement of impact by people, even to themselves, and the understanding of the prevalence and impact by healthcare workers. Our elderly are unlikely to report feelings of sadness, especially outside a concrete reason for the sadness. And they most often do not recognize disturbed sleep, fatigue, withdrawal, etc., as symptoms for depression or of depression. In an initial meeting, especially if a patient's exhibiting anxiety or depression, ending the meeting with just the patient understanding that they have kidney disease and having a sense of trust in their team is a successful initial meeting. By doing an assessment and then bringing the patient back for tailored education or one-to-one with the social worker helps the patient develop a sense of trust and safety and more able to partner with the team to engage in the education and make treatment choices. So some of the things we might see, and we've probably all seen this in some form or another, is a patient may be reluctant to book appointments, they may cancel frequently or just no-shows, difficulty in understanding, concentrating on information that we're providing, and signs of just being overwhelmed. Issues with self-care, including medication adherence. They may have signs of weight loss or weight gain, sleep disturbances, dismissing or contradicting concerns raised by healthcare providers or family, and focusing conversation to safer topics. They might want to divert the conversation and concentrate on diet. They often defer to a family caregiver or show signs of caregiver exhaustion. They often have loss of motivation for interests that they once had and relationships and withdrawal from them. They report memory concerns. They have irritability at times. And oftentimes, if you're in your unit and you hear staff commenting on a difficult patient or that there are no-shows, that could be a sign that that patient may be having signs of anxiety and depression. I need some exploration in that. So during our initial appointment with a patient on referral from the nephrologist, we meet as a team consisting of a nurse, a social worker, and a dietitian. We focus on the understanding of the patient's renal disease with them and observe how that information lands on them. Rather than a predetermined script of how meetings should run, a client-centered approach is designed to determine health literacy and determine how education needs to be delivered. This initial assessment is used to make a collaborative care plan with the patient for further appointments. If coming to the hospital or talking about interactions with the healthcare system is a trigger for anxiety and depression, the patient may be too traumatized to receive information. Very often, it's in their initial appointment that we can actually realize that it's unproductive to proceed with providing information, that our patients are having difficulty absorbing and even detrimental when anxiety and depression is a barrier. If our agenda to ensure that they obtain a certain amount of information overrides a client-centered approach, we may increase their anxiety and depression and contribute to avoidance, resistance, and an inability to come to decisions. Especially for patients with anxiety and depression, to have an interprofessional team, including the nephrologist, nurse, and social worker, and dietitian, working closely and cohesively instills trust in the team and is core in helping the patient move forward in the trajectory of their kidney care.
So we've talked a bit about what it looks like and why it's important. So now we're going to bridge the gap here, and we're going to look a little bit closer at the guideline. BC Renal Agency actually recommends a multidimensional assessment rather than a quick ask or a quick tool in terms of assessing anxiety and depression. So these are the recommendations for the teams to be alert to clinical symptoms. So we've talked about that, and we've talked about some of the overlap between that and even symptoms of kidney disease, but being really critical about that. Universal screening is not indicated or recommended for the CKD population. That said, we certainly do believe in screening. The Edmonton System Assessment Scale has been modified and is research grounded Canadian, Alberta nephrologist, did a lot of work, and that makes a tremendous amount of sense for our renal patients who have a significant symptom burden. So that's not what I'm talking about here. There you want to have routine screening for a number of symptoms, and there you may pick up indications that there needs to be further assessment regarding mood. So though the screening tools are limited, self-assessment requires insight. It's void of collateral information. It can fail in context of confounding aspects of symptoms, and it can be experienced as invasive. And when we're talking about this kidney care clinics, we're not talking about people that we're seeing 3 times a week. We're talking about people that we're seeing every few months. And so we need to be very respectful and honoring in how we approach how people are doing at a very personal level. So if a screening tool is a subjective assessment by a patient, a psychosocial emotional assessment is a very different kettle of fish. While our patient is our primary consideration and our greatest source of information, with the population that we serve in KCC, and I'm talking about the adult population, although the Guideline has a huge section for pediatrics, we're talking about the adult population, and certainly our demographic in the adult population is primarily the older, more senior population. So when we engage in a dialogue with patients and spouse and family member or friend, we often find significant inconsistencies with our patients' self-reports. So tools have a very important place, and they're a wonderful adjunct for us in renal to help us and help our patients understand and monitor their mental health, and to sort of assess for appropriate levels of intervention. So being a social worker, I've got to have a gushy quote. So as self-esteem issues and shame and fear are core to anxiety and depression, it only follows that patients are often very reluctant to share how they are feeling. Depression is often missed or misdiagnosed based on assumptions that patients will self-report the mood problems. And the data is often in subtle indicators that our patients are struggling. It's in the nuances and the meta-communication that the trained clinician can begin to acquire the appropriate data. So that looks like the discrepancies between a patient's self-report and the patient's actual presentation. And again, discrepancies between the patient and the perspective of others. And in the collateral information that we find in the patient's psychosocial emotional history. It's found in what the patients choose to attend to or not attend to in an interview, and what they attend to or don't attend to in an educational message. It's in their nonverbals that are not congruent with their nods and their thanks for the information. And so that is why the BC Renal Agency has come up with a guideline and supports an evidence-based model of an interprofessional approach with collaboration and respect for scope of practice. So moving from that sort of interview piece into the tools that have been identified, and there's a number of great tools that are out there, what they agreed on was the PHQ-9 in terms of taking a quick assessment of depression. It's short, it's user-friendly for the person that is doing the assessment. It's not weighty for the patient who is giving their answers. And it's the most well-known tool for family physicians, so it's a really great tool for us to communicate with other people. So it's not taking away from other tools that are valid, because there certainly are many. And in assessment, we may use more tools, but this is a tool that we've been asked by BC Renal Agency to use as a standard in terms of the depression. So it's already been mentioned, it's often difficult to distinguish between the biological or the physical symptoms induced with the symptoms of the illness. So this issue can produce false negatives and false positives. So it's also difficult to differentiate between the somatic and the cognitive symptoms. And that's very difficult in the medically ill population. So that's all considerations in renal and underpin the BCRA and the research position that these tools need to be done in context of unpacking and kind of making note of what else is going on or what the patient's attributing to and what else is actually going on medically. The bottom line is that identifying anxiety and depression early, providing the intervention and those things, and predicting transitional points where anxiety and depression may be exacerbated, and problem solving in that regard lead to more successful and sustainable transitions and outcomes. Same thing with the GAD. 7 questions, well, research-based, doesn't indicate us so much about the presence of stuff as it actually talks about the severity of the anxiety and depression. And I think this is one of the message BC Renal Agency is trying to get through to us as renal, is we in KCC don't need to be diagnosing any particular anxiety disorder, because we're not going to be the ones that are going to be managing any particular anxiety or depression or any other kind of mood disorder. We need to be aware that anxiety can be interfering with our patient's ability to engage in a meaningful way. And if we catch that in context of our appointments that we have in kidney care clinic, we have the skill set actually right on our team to address and reduce that anxiety up to a certain point, and we want to utilize that fully, that full scope of practice. But also in our assessments and using these tools, we may be indicating scoring that definitely indicates that there needs to be further assessment and diagnosis. And the BC Renal Agency is really encouraging us to refer that on to the family physician in terms of responsibility. But we do absolutely have a role in how we identify and what our process might be for making sure our patients are going to get access to the best care that they possibly can. So I know this is small. I didn't have much time to kind of cut and paste this, but it's just a quick look at, and this is also found on the BCRA website. I'm good for time yet? No, I'm not. I've got like 6 minutes so we can start talking to you folks. So they're going to do some education, like we want our nephrologists to be aware of anything they're concerned about and referring on to the interprofessional team as well. Patients get referred to kidney care clinic. What that looks like might look a little bit different at different clinics, but what's important that the KCC does their team assessment. So we don't assess for one another. Yeah, I can't do an assessment for a social worker. Pharmacists can't do an assessment for a physician. We need to do our own assessments. And then between any of us, any one of us might see something that's of concern. And so the guideline is that if there's something of concern that you think that there may be an issue with anxiety and depression, it has always been a practice standard to refer the psycho-emotional to the social work, so that referral should occur. And then the guideline says that the social worker, the registered social worker, conducts a social work assessment and utilizes the tools as indicated. So out of that assessment comes a couple of things. Either anxiety and depression appear to be likely or they're not. So if they appear to be likely, then we move on to the next slide. So again, it's been stated it's on a continuum. It can be mild to moderate. And in the interest of time, I think I'll even kind of go past the treatment slide to sort of say that the research demonstrates that non-pharmacological is indicated as a first line rather than medication for mild to moderate depression. And so if that's what's indicated, social work is going to explore that further. They're going to talk about what the patient's open to in terms of a plan, what their resources are, what's worked for them in the past. They may have counseling. They may have a loss and grief history that has contributed to where they at, where they're going to resolve whatever we can resolve through the actual skill set and the interventions that are already core to what it is that we do. And we're going to speak to the patient about letting the family physician know that this is what we've discovered, and we'll let the family physician know, and let them know that we're deferring to them as the primary care provider. Some of our patients don't have primary care providers, and so we've been encouraged by BC Renal Agency. It's always been the case. If we don't have a family physician, we try to advocate. There's walk-in clinics. We give resources for the BC College. But again, we're doing everything we can to put the responsibility out that way and make sure that there's going to be follow-through beyond us. And then, of course, the social worker, I don't know how you do it at your clinic, but in our clinic, we debrief after every clinic as a team. And so how we communicate to the patient, we've got examples of letters that the social worker sends the physician, but we're certainly going to be faxing also those scales. And then what we've got is we've got a baseline in context of the other assessment. So we can revisit that in 6 months or 9 months. We've got a baseline to know how our patient is doing. And we've also got the knowledge, especially if we've encountered anxiety and depression, that we need to be watching our patients more carefully at those transitional times. If we find moderate to severe, some of that moderate is just like the moderate from the first slide. Depending on where that is and depending on how the patient's functioning and what the risk factors look like, we might be referring them to community resources. We might be making those referrals to geriatric mental health, or we might be even, often the anxiety and depression are in common with other kinds of mental health issues. It may need that there's an indication for an actual referral to psychiatry. So we're going to work that out. Certainly, when it's moderate to severe, the social worker is going to be doing a risk assessment for suicidality. And when we're doing that, again, you're looking at the severity of the risk. And does that look like providing crisis information? Does that look like developing a safety plan? We're going to go into some case studies as well. It might mean walking the patient down to the emergency department for an immediate investigation. So that's what the algorithm looks like. And I think we can skip through this really, really quickly again. When we talked to the psychiatrists, and the psychiatrists were part of the team that developed this, they talked about the level of NonCompliance and how many people are referred to family physician or referred to them and are prescribed medication. And the patients don't buy in. You know, they don't follow through. They don't buy in. So patients who have declined pharmacological intervention benefit from psychoemotional interventions alone, and very importantly, not at serious, but not at severe, but certainly at mild and moderate. And they can change their mind, and they can become open to be augmented with pharmacological treatment as well, as a benefit of a psychiatric consult as a result of foundational social work. So if we can help our patients become more aware and identify their symptoms, even normalize their symptoms, maybe even letting them, we see a lot, a lot of hospitalizations. How's it going? And they begin to talk about stuff, and even without making it about them, just saying, we see a lot of anxiety and depression and chronic disease. When we begin to normalize that kind of stuff, they actually begin to open up and share with us. And then they begin to make the connections around how that has an impact on their overall health. And then they begin to partner with us and become active in maintaining a sense of control in that regard. And they often resolve their fears about being labeled with any kind of a mental health diagnosis. They begin to relinquish that resistance and experience some benefits from treatment. And maybe, Henry, did you want to say a word about pharmacological? Because pharmacological treatment of depression, that's another workshop, and we've done that. I did that with Dr. Samra. I can't remember what her name. Jody Samra. Yeah, fabulous psychiatrist. But
very brief comment, really. Pharmaceuticals can be a helpful complement to management of depression and anxiety. And quite often, the nephrologist or the doctor does not necessarily initiate treatment from the clinic. I think the important thing is to acknowledge, like Bobby said, to acknowledge that there's a problem, to talk to them about it, and then if it's determined they need further treatment, particularly drugs, then we often like to defer to the family doctor or psychiatrist for initiation of those drugs. There's a helpful guideline, handout at the back of this guideline, which kind of helps us in this step as well.
Yeah. That said, the renal pharmacists have done a lot of work in terms of treatment for anxiety and depression, the renal guideline, and they are a tremendous resource, and work that they've done have been foundational to what's in the guideline. But I think what Dr. Wong is saying is that we're trying to, for the CKD population, for sure, for the kidney, we're trying to defer to the physicians, try to educate them about doing appropriately, trying to educate them about referring them appropriately, because when we've got a renal patient, we've got a renal patient for life. And if they are struggling with anxiety and depression, by the time they're being admitted to our program before these other modalities, we want to begin to have them treated and reduce any contributions that would be negative in terms of their managing their diseases, their anxiety and depression. So we're not bad for time. Did it sound too rushed or not bad? So again, like I said, this is an overview. Now we're going to talk a little bit. We're going to maybe talk about a couple of cases, but we want you to jump in and share a couple of cases. We've only got like one other slide other than questions. So at this point in time, maybe do you need to ask any questions right now, or should we start talking about what that might give us a couple of case examples of how this sort of guideline plays out? Would that be okay? Okay. Go ahead, Henry.
Which one are we doing first? Probably.
Oh, social work interventions. They're based on theory and research. They're brief. They're targeted. There's a point to them. They're focused. We're not opening counseling offices. We're trying to get things going in a positive direction. They're there to support the patient. They're there to support the goals of the renal program, and they're outcome driven. And they include the core competencies that social workers should have in terms of working in healthcare. So now the case studies.
Okay, so I think the first one we'll go over is the case that I presented at the beginning of the talk. Do you need a reminder of the case, or are we good? We're good? Okay, all right. So any comments about that one? So the bad patient, the non-compliant patient, doesn't show up? I'm being facetious, of course.
So are you going to go ahead that you referred?
Well, I think we're trying to invite some comments to see if people want to comment on that situation and whether you've seen that before. Of course you have, yeah. Yeah, so that came up as we delve into the kidney care clinic portion of things, right? Yeah. So I think from my perspective, the challenge was at the office, time constraints, and also how we are typically trained to focus on the patient. So you say, well, these are your medical problems, this is how you deal with it, this is how you manage it, and your kidneys will be fine if you do this. Well, they don't hear that message, right? You can say all you want, but it's not registering. And I think retrospectively, for me, that case, if the psycho-emotional concerns had been recognized early, I may have referred on to kidney care earlier to take advantage of our resources there, because clearly the depression and anxiety really played a big part in then. Of course, I'm not saying that the heart attack is directly related, but you can see poorly controlled risk factors typically lead to poor health outcomes. And
so Henry referred to Kidney Care Clinic, and we did what we do. We do our social work assessment. And of course, when you start to do that history, you start to piece together that all this presentation before the heart attack, or even the presentation for the risk factors that developed even before the had a lot to do with how she was functioning psycho-emotionally. And it wasn't a lot. It was 2 sessions, 2 counseling sessions. And in those 2 counseling sessions, we could find out what the root of that was. And we weren't just hearing a story. You know, it's not about having a chat. It is about how you're functioning and how you're thinking about the world and life and yourself. How is that impacting the kind of choices you're making? And she had a tremendous trauma history. And she probably had been running around with an anxiety disorder from the time she was about 18 years old, and had to leave her children in another town to escape a situation. And so we were able to assess the level of anxiety and depression, which was actually very serious. But she was not depressed, and she was it was very serious. She was not suicidal, and she was certainly not open to pharmacological intervention. So what did we do? We gave her some appropriate referrals to Women's Resource Society and for some trauma counseling, and brought her back to clinic 2 or 3 months later. And then in context of having had acceptance and understanding and the freedom to be able to be okay, she actually said, you know, you mentioned that when people score as high as me, that often medication could be helpful. I want you to know that I'm open to that. So instead of, you know, having somebody be discovered as anxious, prescribing for them, and having them walk away, say, I went there with kidneys, and now they're just telling me I'm a nut bar, you know, and not buying into it. We've actually got somebody who's complying, and she's not a perfect patient, but she certainly doesn't miss appointments. She's got a very strong relationship with us. She's getting her blood work done regularly, which she wasn't doing before. And we see, she's not an isolated case. We see this all the time.
So another case study we had a 58-year-old male that was referred to us, and his GFR was about 23, I believe, when he came to kidney care. So initially in the appointment, we asked, what do you understand is going on with your kidneys? Typical response was, my kidneys are fine, I feel fine. And then he'd proceed to say, you know, I run a construction site, and I can do this and that, and then move on to, and I eat a healthy diet. So he did not want to talk about kidneys. So right at that point, I think Bobby, we all
he
noticed.
He had a diagnosis. He came with us with a diagnosis, and he was being treated with medication. He was being followed by a psychiatrist. Right.
So coming to see us was a change in his condition. We were probably saying things he didn't really want to hear. So this isn't his initial appointment, so we realized this isn't the time to be overloading him with information. He's not going to take anything away. So
we explored what the avoidance was about and said, you know, we understand that you've got some health history. Tried to figure out where was he that he was avoiding talking to us. And then he began to talk about some of the trauma that he'd had in his life. And for him, they were all very much related to interactions with the healthcare system. A couple of things that happened.
So he'd been admitted to hospital with a couple of routine procedures, which turned out to be very complicated outcomes for him, with actually an ICU admission. So just even coming to a medical appointment and being told he's got kidney disease was a huge trigger for him.
And so that equipped us. It's an admission appointment. It wasn't the time to do an assessment. Didn't need to do an assessment. He's already being followed by a psychiatrist. But at least we're really aware, and we're starting to think, what does that mean in terms of your kidney trajectory?
So he became a patient that had a lot of trust in us. He would call and, you know, check up on things and just run things by us. So, you know, he showed that he was really putting a lot of faith in our team. And as his GFR declined, we were able to do a one-to-one options with him. So he wasn't a suitable patient for a group options class. He got a lot out of one-to-one with just Bobby and myself, and he and his wife and his daughter. And he was able to make a treatment choice, and he chose hemodialysis. As his GFR decreased and he became, I guess, around 17, Dr. Wong referred him for vascular access. So we're reassuring him that this is a very normal thing to do. This is the time that we would do this. It was a huge trigger for him. Routine, normal procedures in the past did not go as planned for him. So at that point, his anxiety was very much triggered.
And so when he was referred to the vascular access clinic, he showed up that day without his wife, and we were fortunate in that the vascular access, we were already watching him carefully. I had phoned in the morning to say, everything on track today? And they were like, yeah, everything's on track. And I said, will you let me know if anything goes awry? And they said they would. And actually, no, I didn't call them. The wife called me and said I didn't come in. And she just said he seemed a little upset. And it was just actually as the vascular access surgeon was getting him to sign the consent form for vascular access, I said, can you just excuse me a minute? I'd like to talk to him. And he was actually incredibly suicidal. Heather and I walked him down to emergency. He was admitted for 6 weeks. So he was extremely suicidal. So those are ways, I think we're talking about a guideline. This isn't a make-work project. I think BC Renal Agency is saying, you guys know what you're dealing with. You do this all the time. We just want to make sure we're doing it in a kind of standardized way, and I hope some of our stories are resonating with you. Really, I think at this point in time, do you guys have some questions, some stories? Anything you'd like to add to this discussion? Are our stories resonating with you? Yeah. No, I think the guideline, I can't talk to children. I'm sorry. Love my children's friends, my friends' children, but I'm not the expert in children renal. In terms of any adult, this guideline is working. This guideline has worked for young adults. Absolutely. It's worked for married people, single people. I think we did make some reference to the complexities and the comorbidities, and that the more senior, like they have a harder time saying, I'm sad. Like, they might even say they're sad, but they have to give you a reason for it. Well, I'm sad because I'm worried about my daughter because she's whatever. They feel they have to give a concrete reason. But the guideline works. We're looking for those physical symptoms that are part of anxiety and depression, and we're looking for those nuances. And those things present. And I think some of us, when my nurse and my doctor are looking at my patient, there's data that just jumps out at them that I don't see, And that's the same as when I'm myself as a social worker is looking at a patient. There's data that jumps out at me, and so I think part of this goal is just making sure that we're kind of all doing our own assessments and sharing that our patients, they're all unique. And I think that's reflective of what Adira said today. She talked about the more we understand about renal, the more we understand we're working with individuals, that kind of thing. Yeah. I was very aware of that this morning about outcomes. We need to discuss further how we're going to measure outcomes. Previously, with the comorbidities, a lot of clinics didn't capture anxiety and depression, and that has become a priority in renal to make sure that we are capturing our anxiety and depression in our comorbidities. So that's going to at least give us better information about what's occurring. And we would be talking about clinically significant anxiety and depression, but we can find that in our renal departments. But yeah, I think we have to find ways of how we capture. We already know that those with anxiety and depression die earlier. All those that have more complications, I'm not the statistician who's clear on how do we capture the difference that we're making, but I'm very proud of our provincial renal agency, like in developing the kidney care clinic per being a leader in raising practice standards. And I'm sure we're going to come up with something in this regard with this guideline. It's a very good question. Very important. What good is anything without outcomes?
I have a question. In this age of Fitbits, where we analyze our sleep, are you having any people sort of self-reporting that to you, or because that's a big component of anxiety and depression, quality of sleep, which may be metric, but are you seeing that at all?
I'm going to let you two answer that as well, but I do want to say from a social work perspective, and I don't know if this answers your question because I don't think like a scientist, but when we hear about people having sleeping problems, they've already demonstrated that non-pharmacological interventions is, again, the first choice. Yet we often prescribe. One of the most important questions is to be asking, why aren't you sleeping? And yes, when we're doing our social work assessment, when we're talking about difficulty in sleep, are you not sleeping because you're getting up to pee every hour because your GFR is 19? Or are you not sleeping due to pain? Or are you not sleeping because you've got really anxious thoughts? And what are our ways? Was that have something to do with your question? Or can my...
Fitbits will track sort of the restlessness of your sleep period, how many times you wake up, et cetera.
So that's on your iPhone? What is that?
It's kind of like this, but smaller.
So, as I said, the technologically
I
savvy
think
people
maybe
have to
because of our population, most of them are older, patients, and they don't. Right now, anyways, I'm not seeing that in my patients. They're not coming and saying, "Here, my Fitbit is telling me my heart rate's been like this and my sleep's been like this. Work with it," right? So I'm not seeing. Maybe they're telling you.
No, I haven't either.
No. Even his lovely, mature colleagues aren't doing that Fitbit thing.
I don't see people with Fitbits, but I'm a nurse practitioner in a hemodialysis setting, but often people will talk to you about fatigue and sleep and concentration, and that is sometimes less threatening place to start.
Exactly. Yeah, we don't usually, when you do a social work assessment, we don't say, do you have an anxiety and depression history? You're saying, tell me a bit about yourself and what were some really memorable times and what were some really difficult times. And then, and what does your day look like now? And you start to pick out those things and then just say, is this concerning? Is this interfering with your life? Yeah, very good point. And that's this kind of scary thing about doing a screening tool anyways, because when you hand a tool, it's an anxiety thing, and it's like, it's none of your business. I'm not even going to answer this, honestly. I mean, I think once they're on hemodialysis, they want help with their symptoms. They're going to be more straightforward. But we've got to be careful how we present things to our patients. Any other questions? We got down to 2 minutes. Yes. Oh, Oyman. Response is fabulous. I had one doctor once when we made a team referral to a seniors clinic give me a phone call and say, I am the care coordinator. But we've probably done 300. Many people, almost anybody, other than the patients that are disengaged from their patients and haven't done any follow-up at all, we get everything from letters back, thank you, thanks for letting me know, thanks, because sometimes we've gone to pharmacy. Now we've got a guideline, so we've got a handout. Before we used to just go talk to our pharmacist. He was on Celexa, 12 years ago, he was on something, and, he's scared of this, he's scared of that, what would you recommend? And we've given that recommendation to the family physician. Family physicians have been lovely, very appreciative. And almost always, you've sent them a message when they come back next time. They're on something that we've recommended, and how are they doing? They're doing much better. Some do. Some do, yeah. Some do. Most of our patients have regularly scheduled patients. Again, I'm looking at a demographic that is pretty much going in to see their family physician about something or another every 4 weeks. So I have never sort of said, please contact your patient. And I've never, there's a few times I said, so we're going to send this into the family physician. Will you make an appointment with him for next week? And I'll have that in my letter. We've recommended he make you an appointment. But you're always going to have some disengaged practitioners. That doesn't matter if it's social workers, nurses. You know what I'm saying? We've got a few physicians that it's more of a challenge with. But, I mean, if it's urgent and emergent, you need it done in a timely thing, you're going to be calling geriatric mental health directly and making sure an appointment's set up before your patient leaves your clinic. Right? Good question, Zoyman. So we got 40 seconds. Are we done?
It's over.
Oh, it's over.
Counting over.
Oh, we're counting over. It's break time. Thank you for your input. I don't know. Has he turned us up? You got stuck. Do you know Dan?
Yeah.
From Victoria, pharmacist, wonderful pharmacist.
Sorry.
Did it fall out?
I know. I just want to say hello. I'm back.